morning, good afternoon, and good evening to all our speakers, chairs, and the wonderful audiences in different parts of the world. Welcome to ACNS webinars. The speaker for the first session of today is our honorable guest from Istanbul, Turkey, Professor Salim Senturk. Professor Salim is an associate professor at the Memorial Bahçelievler Hospital, Istanbul, Turkey. He is particularly interested in endoscopic spine surgery and deformity surgery. He has conducted studies in spinal disorders in adult patients at the University of California, San Francisco and Spine Center, and also spinal tumors at the Rhode Island Hospital. Dr. Sentur's research focuses on spinal pathology and new techniques on spinal surgery. He is a noted author with several publications in various peer-reviewed journals. He is also an invited faculty to various workshops and conferences around the world. We are extremely honored to have him today at our webinars, and today he'll be talking about endoscopic lumbar spine surgeries. The speaker for the second session of today is our honorable guest from China, Professor Yuan Yasheng. Prof. Yuan is the director of the Lateral Skull-Based Tumor Center at the INENT Hospital, Fudan University. He is also the vice president of the Institute of Otolaryngology at the INENT Hospital, Fudan University. He specializes in diagnosing and treating diseases of the lateral skull base. The focus of his clinical practice is on the management of acoustic neuromas, facial neuromas, temporal bone malignancies, and jugular globular tumors. He is also an experienced surgeon in the most common otology surgeries. He has over 50 publications in various internationally peer-reviewed journals, and he was a pioneer who led to the development of China's first expert consensus on facial neuromas. We are extremely grateful to him for accepting our invitation to be a speaker at our webinars, and today he'll be talking about classification of lateral skull-based tumors and strategies for facial nerve preservation. The chair for the first session of today is our honorable faculty from Seoul, South Korea, Professor Yuan Kim. Prof. Kim is a world leader in endoscopic spine surgery. He is the founder and director of the Harrison's Spine Artist Hospital, Chungdam. He is also an adjunct professor at the Medical College of Chosun University. He was the past president of the Korean Research Society of Endoscopic Spine Surgery, and he is also on the directorial board of the World Spinal Column Society. He is an invited faculty to several workshops and conferences around the world. He is a noted author with over 3,000 citations in various international peer-reviewed journals, and we are extremely grateful to him for accepting an invitation to chair the first session of today's webinar. The chair for the second session of today's webinar is our honorable guest from Japan, Prof. Hirotaka Hasegawa. Dr. Hasegawa is an assistant professor in the Department of Neurosurgery at the Saitama Medical Center, Saitama Medical University. He was previously working as an assistant professor at the University of Tokyo Hospital, Japan, where he was the chief endoscopic skull-based surgeon. He has abundant clinical and research experience in endoscopic skull-based surgeries, including picnets, meningiomas, chordomas, and chondrosarcomas. He was a past fellow at the Mayo Clinic in Minnesota, USA. He has been honored with several awards and honors during his career in neurosurgery. We are extremely grateful to him for accepting an invitation to chair the session of Professor Yuan Yasheng. On behalf of the Education Committee of the ACNS and the President, Prof. Yoko Kato, I would like to welcome both the speakers, chairs, and all the wonderful audiences around the world to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Professor Shubin for broadcasting this webinar on the WeChat channel. Dr. Liu Boon Seng from Malaysia is my co-host for today, and with that introduction, I would like to hand over this online podium to our first chair, Professor Yuan Kim.
Okay, can I share my slide? Nice to meet you, everyone. I'm Hyun-Sung Harrison Kim, Harrison Spine Artist Hospital, Cheongdam, South Korea. This webinar held the Asian Congress of Neurosurgical Society. Nice to meet you, every member of the Asian Congress of Neurosurgical Society. And today we prepared two lectures. First lecture will be the endoscopic lumbar spine surgery, and second skull-based surgery. And as a neurosurgeon, we know that already the people's middle life increased so much. Because of that, some need of the medical treatment by the neurosurgeon increases so much more, and especially the spine surgery will be the main portion of the neurosurgical part, and especially endoscopic spine surgery mainly leaded by the neurosurgeon. Because of that, our role of the as a neurosurgeon, it is very important to the future medical parts. And also, fortunately, endoscopic spine surgery developed so much from the first generation discectomy and the current generation of fusion generation. And also the instrument, not only the surgical techniques, but also the instrument and the view and the surgical instrument all improved so much. Now we can take a more clear and more close and more safe operation. Then meaning that as a neurosurgeon, endoscopic spine surgeon, we can give more good treatment result to the patient. And this data showing the our my hospital's last 9 months, we achieved 10,000 cases of 1,000 cases of endoscopic spine surgery. Then we only done the 3 cases of the open surgery, only for the ACDF. It means that if with the development of the endoscopic spine surgery, we can really 90% of the degenerative spine disease can give using the endoscopic spine surgery and can give them a good clinical result. That is a very important role as a spine neurosurgeon. And fortunately, with this development, we also can decrease the fusion rate so much. And also, so degenerative patient, all the geriatric patient can easily managed by the endoscopic spine surgery. And then now we believe that in the future, we can really possible as an endoscopic spine neurosurgeon, we can really serve as a no open surgery, no suture, no dressing, no transfusion, no general anesthesia for degenerative spine disease, and minimizing the infection after operation. Today, Dr. Salim Center will give the talk of the endoscopic lumbar spine surgery. He is a master and master of the endoscopic spine surgery. Now we're waiting his great lecture for Asian Congress of Neurosurgical Society members. Dr. Salim?
Thank you so much, Dr. Kim. Thank you, ACNS, to invite us for this webinar. Thank you, everyone. Dr. Kim explained, Dr. Kim, the brief for this approaches, and I will talk about endoscopic lumbar spine surgery. And there are a lot of endoscopic systems for perform these surgeries, monoportal system, biportal systems, and there are a lot of tools. And I use the uniportal endoscopic system mostly, and the inner size of this system is just 4 millimeters. There are a lot of type: 4 millimeters, 3.6 millimeters, 4.5 millimeters, 5 millimeters inner size of these systems, and the outer size of this system just 6.9 millimeters. Just skin incision just less than 1 centimeters mostly, and just one stitch. Just mostly you didn't put anything. And this is our systems, and I follow this nomenclature. 2020 our spine published article for describe this terminology. I use this terminology, and during my presentation I use this terminology, but there are a lot of modified techniques for perform endoscopic systems: transfacet surgery, transpedicular approach, translaminar approach, and there are a lot of approaches for perform these surgeries, but I use this nomenclature. What are the and we use endoscopic system a lot of pathologies. Here this list is growing day by day. These days we perform the surgery all type these pathologies, all type spinal stenosis, but sometimes we use this endoscopic system for infection, for pars fracture, for vertebral fracture, some kind of complication of the vertebral surgery, cement leakage, or screw malpositions. And these days we use these systems, the spinal metastasis, and we perform the tumor surgery, epidural tumor surgery, and intradural tumor surgery. It is a big solution for the spinal pathologies. Advantage of these systems, there are a lot of advantage. Dr. Kim said something about this. You may do the surgery under local anesthesia. It is important things. And skin incision just 7 millimeters. You may see less soft tissue injury, less muscle injury, and less iatrogenic instability. You may discharge patients same days, and you may mobilize the patients after the surgery. Maybe 30 minutes later, you may mobilize the patients. There are a lot of advantages of these surgeries, but still we get a disadvantage of this surgery. What is the disadvantage? The radiation exposure. We study on this problem, but still we get a problem for this. For patient, for all staff in operation room, radiation is another problem. And educational period, it takes a long time, more than a microsurgery. I will explain the step-by-step, case-by-case interlaminar approach, first of all. And step-by-step, I will talk about it. Here is the endoscopic, here's the case, large base disc herniation, L4, L5 level. What is the important thing of these surgeries? The important things, you need to know all steps, and you have to follow some rules. If you lost your position during the surgery, you need to check your position and C arm, and you need to know in your head, where is my position? After that, you can go into surgery. But large base disc herniation got an important problem, and I will explain later this one. Here is sorry. Entry point should be 6 or 7 millimeters lateral from the midline should be. And here is the lateral view of the X-ray. Your target point, interlaminar window, just you need to put the working channel surface of the lateral border of the facet joint, and you need to see the ligamentum flavum. Sorry. Here is, sorry. Here is the view of the working channel. Here is the muscle tissue here. Here is the ligamentum flavum. You need to remove all tissues, subtissues, and you can cut the ligamentum flavum. If you get a big size, large base disc herniation, the disc tissue can push the nerve tissue to the border of the facet, superior articular process. For protect the exiting, traversing nerve root from the image, you need to see all tissues you cutting, and you need to remove and medial border of the ligamentum flavum. And here's the nerve tissue. Here is the disc tissue. You can remove the disc tissue under the traversing nerve root. If you push the nerve tissue to the medial during the surgery, you can damage the traversing nerve root, all tissues. Sometimes you need to change your position. You need to create a free nerve tissue. After that, you can going to do the surgery. Here is the nerve tissue. Here is the border of the inferior vertebra. And the end of the surgery, you need to see the clear vision on MRI. But most important problem of this surgery, large base disc herniation. During the surgery, you can distract the nerve tissue to the medial. And if the time of the surgery takes a lot of time, you can damage the traversing nerve root. This important problem. Here is L5 S1, same surgery. And you need to remove the ligamentum flavum. After that, you can push the nerve tissue, but you have to change the position of the working channel during the surgery. First of all, you need to dissect the nerve tissue. After that, you can remove all these tissues. like this. Here's the disc tissues. You need to create a free space, and the nerve tissue is free now. And post-op MRI. And what is the important things of these type surgeries? If you are a beginner level endoscopic surgeons, you should be very careful when removing this type huge disc tissues, because distraction time is important for this. And here is the view, endoscopic view of the annulus fibrosis. End of the presentation, we can talk about this. And should we cut this ligamentum annulus fibrosis during the surgery, or should we follow some another rules? If you have a damage of the annulus fibrosis, you can use this damage to remove some disc tissue, some protruded part. But if you don't have damage of annulus fibrosis, you may use the border of the ligamentum flavum, because annulus fibrosis. The annulus fibrosis is weak, the border of the vertebra, but center of the annulus fibrosis is strong one. If you remove the disc tissue, the border of the vertebra, you can protect the annulus fibrosis. If you cut the center of the fibrous tissue, you damage the fibrous tissue. Maybe we can talk about it, especially Dr. Kim. I will ask this question to the Dr. Kim. And another case, up-migrated lumbar disc herniation. How? What is our approach? The same procedure. The 6 or 7 millimeters distance from the midline. Our target point is the disc tissue. Here is the just you can cut the ligamentum flavum. After that, you can see the disc tissue. But on MRI, we know where is the big, huge part of the disc tissue. You need to follow the disc tissue. You can check your position on CT and C arm. Here is the other extruded part. You can remove this tissue, and you can check is there any disc tissue or not. After that, you can finish the surgery. Here is the MRI. Another one, the upper level up-migrated lumbar disc herniation. And for this surgery, you can you get two options: transforaminal approach, interlaminar approach. You can do this surgery transforaminal approach, but and you can do interlaminar approach. And entry point for these patients, you before the surgery, you can describe your entry point. Here is your center of the huge disc. Here is a disc tissue. If you follow this one, just you can see the disc tissue, but you need to see the center of the disc tissue, and your entry point should be a little bit down, and here is the axial view of the surgery. Just 7 or 6 millimeters is enough. Here is entry point a little bit lower level, and for remove the upper level up-migrated disc surgeries, and we are cutting the ligamentum flavum. Here is we cut a little bit bone, and here is the disc tissue. You can distract the tissue to the medials, and the huge part here you can remove it. After the surgery, you need to check is there any extruded part. And here is the laminotomy. You may see that here. Just a little laminotomy is enough for this surgery. Another one, down-migrated disc herniation. The same procedure, but before surgery, you need to, here is in the laminar window is a small one, and we need to see all this area during the surgery. and your entry point should be different from classical interlaminar approach, a little bit cranial. Before surgery, you need to know it. Lateral view, and here, step by step. Here is the superior and inferior superior medial lateral border. Here is the foramen. Here, the ligamentum flowum. Here is the lamina of LS1. Like microsurgery, and here is the shoulder of the S1 nerve root, and here is the part of disc tissues. Shoulder, the pedicle nerve, and the shoulder part of the disc, and here is the shoulder, and after that you may check the axilla. Here is the axillar part, and disc tissues. Here is the axilla. Here is S1, the medial dura. Here is the axilla, and here is the axilla, and you can check all around, and the postoperative MRI. The axillar approach is a little bit different, because during the surgery you may see the bleeding. There are a lot of vessels coming from axilla. If you remove the extruded part, you may see the bleeding, and you need to control all bleeding. Another one, the just one entry point, bilateral endoscopic discectomy. This is a high body mass index is the advantage of endoscopic spine surgery, especially multi-level disc herniation. If you have a high body mass index, your fat tissue, just skin incision, just one, you can change the position of the skin, position of the fascia. You can do another level surgery. It is a high body mass index is a advantage of endoscopic spine surgery. Here is skin incision, just one side, just one, the left side endoscopic surgery. After that, right side endoscopic surgery. Step by step, you can follow this. You can do these surgeries, but skin incision just one, and fascia incision is both sides, and both side endoscopic surgery with just one skin incision. The other side, here is the ligamentum flowum. Here is the superior articular process of the inferior vertebra, and you can remove the lateral border. You can distract the nerve tissue to the medial. After that, you can remove the disc tissues. Your eyes into the spinal canal. If you want, you can do everything. What do you want? You can do it. Here is the postoperative MRI. And this is just disc surgeries, all type disc surgeries. You can choose this problem, disc pathologies with just interlaminar approach. And another one, transforaminal endoscopic lumbar discectomy and foraminotomy. What is the important thing of these surgeries? This is entry point from 6 millimeters to the 11 millimeters distance from the midline. Your entry point, your target point, just combine triangle for these surgeries, and your focus, just target point is important. Before surgery, you need to know your trajectory, your angle, but a safe area is combine triangle, and you need to know the compression is enough or not. And the end of the surgery, you need to check all tissues. You need to create a space for nerve tissue, and you need to know if it's okay or not. Here is the case. You can see here there is a laminectomy defect the other side, and the right side there is a compression to the L4 nerve root. If you put the working channel to the combined triangle directly, you can damage the exiting nerve root. and you need to create a hole for perform the surgery. Your target point is a superior articular process of the inferior vertebra. You need to touch this vertebra. You need to remove the bone. After that, you need to remove the soft tissues, ligaments, and you need to create a hole for L4 nerve root. And here's the video. Our target point. Here is the bone, superior articular process of the inferior vertebra. This is our target. And here's the bone. You just touch the bone. You need to remove the bone. You may use the shaver, diamond shaver. There are a lot of types. Top of the shaver is a spinal canal. The right side is a cranial. The left side is caudal. The medial and the caudal side, lateral side. You can remove the bone. After that, you can remove the all ligaments, ligamentum flavum with intra and intraforaminal ligaments. End of the surgery. Here is the nerve tissue and foraminoplasty. And you can discharge these patients same days or next days without any instrument or anything. Here's the case. Patients get a losing and foraminal stenosis. Here is the foraminal problem. Here is the superior articular process of the inferior vertebra, S1 vertebra touching the L5 nerve root. Here is our target point. After that, and here is the top of the. Here is the border. The top of the superior articular process. Here is the top of the S1 superior articular process of the S1. Our target. We use the shaver to remove this part. This part is touching the exiting nerve root, and we create a hole for L5 nerve root. And here's the fat tissue, and here is the hole for S1. Postoperative MRI and free L5 nerve root. Just we use this incision, just maybe 4 or 6 centimeters away from the midline. Here is the we removed all losing screws. Another one, there are a lot of options for transforaminal approach. There are a lot of modified technique. A lot of modified technique. Inside out, outside in, half and half. There are a lot of modified technique for transforaminal approach. My practice, I do mostly 90% interlaminar approach, and maybe less than 10% transforaminal approach. My experience. This one is extraforaminal endoscopic lumbar discectomy. Here is the. I think it is a. It's not easy. Extraforaminal surgery. It's most problematic surgery, maybe endoscopic in endoscopic surgery. Here is L5S1 extraforaminal disc herniation. Here is target point, just disc tissue. During the surgery, mostly you cannot touch bone tissue. You can lost your position. If you lost your position, you need to check the arm. Where is my position? You need to know where is your position. Sorry. Here is the target point. Just you know the focus target point. Here is the just walking channel cranial part of the L5 nerve root. Here is the disc tissue protruded part. Here is the, and we can remove the tissues, and you can coagulate everything. Here's the huge part. End of the surgery. This, you can do this surgery under local anesthesia or general anesthesia. It depends your and patient's choice. Another one, spinal stenosis. It's like disc surgeries, but for this surgery, you need to remove the bone tissues more than disc surgeries. Here is the facet hypertrophy, more than 1.5 centimeters. And the bone, ligament and filament and bone tissues. We use the shaver, protecting shaver or diamond shaver. Here is the main dura. You need to know that the nerve tissue is not here. Nerve tissue in under the facet joint. And you need to remove the facet joint a little, medial part of the facet joint, superior articular process of the inferior vertebra, the border. Here is the nerve tissue. Here is the main dura. Here, nerve tissue. Here is the traversing nerve tissue, and the compression is okay or not. You can see the C arm. Here is the CT scan. Another one, and fusion surgery. But I use fusion surgery for fusion surgery biportal endoscopic systems. You may do this surgery in portal system, but I don't get it. I get a biportal systems. Like microsurgery, you need to focus the combine and the pars interarticularis. Here is our target. Here is the trocar for chest surgeons. I took this one as chest surgeons. It is good one and cheap. Our target here is our target. I use the shaver, microscopic shaver. This one, it is. I use this one is inside this working systems. Like microsurgery, you can do everything. You can do facetectomy. You can see the exiting nerve root and traversing nerve, exiting nerve root and main dura. You can do discectomy. Here, after discectomy, you can put the cage to the disc space. Here is the cage. The cage here. And here is the exiting nerve root. It is one. Here is the main dura. This one. And here is the exiting nerve root. This one. After that, you can put screws. Okay. Just 4 incision, 4 screws, and the same incision you can do surgeries. And another cases, we published all these cases. Cement leakage. It is a complication of the vertebroplasty or kyphoplasty. If you see this type problem, and you can solve this problem, just endoscope. We follow this cement on C arm. After that, here is the eyes, and you may see that this one leak part of the cement, and you can dissect the nerve tissue. After that, you can remove This is a complication, and you can manage with minimal invasive with endoscope. We published this one 2018. Here is the translaminar approach. Just our target is a cement. Just we can see the target as a cement, and you can remove it. It's the options. Another one, screw malposition. Especially fusion surgery, degenerative spine surgery, some complication is screw malposition. 3% is a complication we may see. If you get endoscopic systems, and you don't need open surgery, just endoscope, just you can cut one part of screw and you can finish the surgery without any big surgeries. Screw with cement leakage. Here is we follow the cement and we follow the screws. We use the shaver. We distracted nerve tissue to the medials. Here is the screws. Here is the cement. You can cut the border of the screws. Here is the cement. The medial border of the screw is cut here. Another one, vertebral fracture, especially older people, has a big problem for this osteoporosis, and vertebral fracture is an important problem. What is the solution? Is a fusion surgery, kyphoplasty, vertebroplasty. There are a lot of options, but if patients get a radiating pain, the kyphoplasty or vertebroplasty is not enough. You need a decompression surgery. And what kind of decompression surgery we can do? The minimal invasive approach is the best one. We do the decompression with endoscope. After endoscopic view, here is the video. We put the cement. Here's the left side. There was a symptom on left side, like disc surgery. Here's the bone fractured part. That part is pushing the nerve tissue, and we distracted the tissue to the medial. After that, we removed all bone. We use protective shaver for. Here is the space. We removed all bone. After endoscopic view, we put the cement from the other side, but cement is coming our side. We push to the cement to the top of the vertebra. We create a strong vertebra here. We pushed all cement to the anterior part of the vertebra. Here. Here's the nerve tissue and the end of the surgeries and the postoperative view of the patients. It is a maybe best option for this type patients. Another one, spinal metastasis. It is another big problem for metastatic patients. For us, it is like disc surgeries. Before the surgery, you need to embolize the nerve because the bleeding is important for the surgeries. After the embolization, this surgery is the same disc surgery. The same unit of the tumors, and you can remove the tumors. You can do biopsy, or if you want, you can remove the all tissues or not. It depends your target. Here is the tumor tissues. End of the surgeries, and the patients came our polyclinics with pain, and the patients get maybe 3 or 4 types, maybe daily 10 or more pills he took. But after the surgery, just one painkiller it was okay. Another one, intradural tumor. It is a step of the endoscopic surgeries because what is the importance of the surgery? It is the pressure of the water. It is a CSF pressure, intracranial pressure. How can you manage intracranial pressure during the surgery, during the endoscopic surgery? And after these surgeries, we can answer a lot of questions. Here is the tumors, intradural tumors. It was a meningiomas. We do translaminar approach. We remove the one part of lamina. We create a hole to perform the surgeries. And after laminectomy, here is the dura. We use some tools to open the dura. Here is, but we didn't put the camera into the spinal, into the dura. We removed one part of dura. Here is the tumor. Tumor surgeries. We distracted the nerve tissue. After that, here is the dissector. We removed all tumor tissues. Here, our eyes into the dura here, and we removed all tissues, tumor tissues. End of the surgery, we are checking around. How can we close the dura? We use the dural mesh to close it. After one, we use the fibrin glue. And here is postoperative MRI and CT. Just window of the here is just window of the lamina here, and 30 years postoperative, 30 years of patients was perfect, and there is no symptoms and there is no problem. We published this one in 2019. And thank you so much. There are a lot of indication to perform the surgeries, and this list is growing day by day. I think maybe future we do everything, maybe 90% endoscopically. Thank you so much for invite me for this great meeting. Thank you, everyone. Listen us. Thank you so much.
Thank you so much, dear Dr. Salim Center. Congratulations for your great lecture. Maybe there have any question in the Zoom members? Maybe because
we can hear your expert remarks and then involve the audiences.
Yeah. Actually, I already mentioned that the endoscopic spine surgery already developed so much, and we know that today we get a great lecture from the Salim Center, and then as a neurosurgeon, especially as a spine surgeon, there is our task to developing the endoscopic spine surgery for the future people's happy life and people's healthy medical treatment. And I believe that the ACNS, Asian Congress of Neurosurgical Society members, will give a main role as for developing the neurosurgery, not only neurosurgery, but also spine surgery, especially endoscopic. And I believe that the endoscopic spine surgery will be a main role at this part. Thank you for all attendance. Yeah.
Thank you.
Thank you very much. Wonderful session from very honorable Professor Salim Centur, and we learned a lot. We can open the house for discussions and questions if any. Dr. Liu, would you like to ask something?
Thanks, Prof. Salim, for a very nice lecture. I have three short questions, Professor. One is regarding upward herniation. How do you decide whether to come in from the same level or the level above? Which one is actually the preferred one for the upward herniation? My second question for Professor, for redo surgery of neuroforaminal stenosis with a previous partial fascectomy. So what are the options available, especially due to a bony stenosis? My last question, Professor, you show us on extraforaminal disc herniation. What are the typical symptoms of those patients where we can be certain those are the culprit of the symptom perceived by the patient, and that's the disc that we need to remove. Thank you, Professor.
Thank you so much. For extraforaminal disc herniation, the patients get severe symptoms, especially pain and the numbness or some kind of muscle problems. If you get this type problem, you need the surgery for the patient. But the surgery is not easy from the other surgeries. The transforaminal approach is the better than one, because during the surgery you can put the working channel to between disc space or between the bones, and you can do surgeries easily. But transfer and extraforaminal surgery, just your hand is during the surgery just stay there without touching any bone. You can lose your position. It's not easy. And end of the surgery, you need to know, and you believe you removed all disc tissues, extruded part of the disc tissues. It is the important problem, and your target point should be at disc tissues. Another important problems, but you can follow some safe approach. What is that? You can touch the superior articular process of the inferior vertebra. After that, you can move the working canal to the disc space, and you can remove all tissues. It's a safe process. This is a walking technique or sliding technique, the safe approaches. And the other one?
Second is redo surgery for foraminal stenosis.
For foraminal stenosis, and if you put the working channel to the combined triangle directly with foraminal stenotic cases, you can damage the exiting nerve root. For this case, you need to create a hole. You need to remove the superior articular process of the inferior vertebra. You need to remove it. After that, you can move the working channel to the inside. If you want disc space, if you want outer part of the disc space, or what you want, you can do it. You need to create a hole for these surgeries.
How safe to remove the part of the body? Because previously have done vasectomy.
No, not vasectomy. Just superior particular process of the inferior vertebrae is enough. Not total vasectomy. Not.
And upward herniation, coming up from the same level, or upward herniation, whether we come from the same level or the level.
No. Same level is okay. I choose same levels. Yes, I can. Yes. You can follow the yes, same level.
At any time that you choose a level above to fish the migrated disc.
If possible, which one is suitable for these patients? Which one? You need to check MRI. I do mostly the same level. If you high migrated disc herniation, like next to the upper or high up level, you can use the other level.
Thank you very much, Professor. Thanks.
Thank you.
Okay, Salim, there have 3 questions. Maybe first question, Harshad Parek talking that maybe you retract the nerve medially or laterally when removing disc. First question.
The retraction is important problem for the surgery, and retraction time another important problem. During the surgery, you need to change the working position of the working channel. You need to create a empty nerve free nerve root during the surgery. If you take a lot of time, you can damage the traversing nerve root. You need to change your position. And if you have a huge central disc herniation, you need to remove the lower part of the disc herniation. End of the surgery, you need to distract the nerve tissue. And your entry point should be a little bit lateral, not classical interlaminar approach. A little, just 1 centimeters or 1.2 centimeters lateral from the midline, it should be. And first of all, you need to touch the superior articular process of the inferior vertebra. You need to remove this part of the bone. After that, you can remove the disc tissue without distracting nerve tissue more. End of the surgery, you can distract the nerve tissue. If you follow these rules, you cannot damage the traversing nerve root. It is important.
And there have two another important question. Second question is how do you manage direct here? Second question.
Yes, it is a good question. Sometimes you cannot see the damage of the dura. You cannot see it. But if you see the dural damage, and the most important things, defect of the what is the size of the defect? If you see the size more than 1 centimeters, more than 1 and 1.2 centimeters, you can use some kind of match or stitch for closing. It is important. If you see the damage but less than 1 centimeters without any problems, it's okay. You can close the systems.
Okay, final question also very important. UV or translaminar approach or transforaminal approach is advisable for discectomy.
Yes. If you get the systems, you can try it.
Okay.
What kind of surgery will you recommend for discectomy? You bipolar or unipolar transforaminal?
I get it.
Yeah,
Yes. It depends your what kind of tools you get it. I get a uniportal systems. I use the uniportal and my experience, especially uniportal systems. But for fusion surgery, I use biportal systems. I don't have uniportal systems for fusion surgery.
Okay. Thank you so much for your great lecture. I think that maybe we already get the great lecture and the great comment and great question. Okay.
Thank you so much.
Raja?
Thank you so much.
Yeah, thank you very much.
Yeah.
We had a very nice discussion and question. Just one more question I would like to put across to Prof. Salim is, have you tried these surgeries in awake patients? What is your experience?
Yes. For transforaminal and extraforaminal approach, just local anesthesia is okay. But for patient is comfortable, but for me it is not comfortable. Dr. Kim say something about is some patients it's a problem for during surgery. But interlaminar approach, I do general anesthesia.
Okay, thank you.
Maybe that is very important. That is that some wake-up surgery will be very important, but with the anesthetic method development also very important. In Korea, many endoscope surgeons use the epidural sedation anesthesia. That means that not general, but as a locally. But the patient is sleep because of that. The patient also take some safety. Free and not going doing the general anesthesia. That also very good to the patient. The receive operation.
Good one.
Yes, Professor Mathuria, you would like to say something?
Hey, what is the status of microdiscoidectomy in the paracentral disc in the endoscopic era?
Yes, it's a big problem for endoscopic surgeries. If you have a central disc herniation, huge one, your entry point should be a little bit lateral for interlaminar approach. And the entry point should be more than 1 centimeter lateral from the midline. And your target should be a superior articular process of the inferior vertebra. You need to remove this bone, and you need to remove the ligamentum flavum. After that, you can remove the disc tissue without distracting nerve root, because you can remove the disc tissue, and after that you can distract the nerve tissue and you can remove it. There is a little modified approach. for this.
Today, Salim Sentuk showed the great cases of L5S and bilateral cases. It looks like very difficult, and Salim also talking that that is very difficult part of the endoscopic spine surgery. But maybe with the development of the endoscope discectomy and then the decompression, laminectomy, maybe in the future the bilateral and extrafemoral pathology is not difficult in the future.
I hope
With the
so.
development of technique, yeah.
Yes, I hope so.
Yeah.
Okay, thank you
Yes.
very much everyone for joining in. It was a wonderful session and we learned a lot. I would like to inform all the viewers that this has been broadcasted on YouTube, WeChat and Zoom. Thanks to Professor Shubin. We have now around 540 people who have logged in through all different channels from in all over the world. So thank you very much. Thank you.
Thank you.
I'll hand this podium over to our very honorable chair, Professor Hirotaka Hasegawa, who would say a short introduction about lateral skull-based tumors and invite Professor Yuan Yashing for his lecture. Hasegawa.
All right. Thank you very much, Dr. Raja. So again, my name is Hirotaka Hasegawa from Saitama Medical Center, Saitama Medical University. It's my great honor to chair this session. Actually, I know everyone is eager to hear the presentation, so I will keep my comment real quick. So as you know, understanding the facial nerve's complex anatomy is paramount in skull-based surgery. The facial nerve has a long and intricate pathway originating in the brainstem, taking a really complex route inside the temporal bone and branching out to the facial muscles. This complex anatomy necessitates a detailed understanding to avoid unwanted damage during skull-based surgery, such as retrosigmoid approach and transpedalosal approach. Unfortunately, lateral skull-based tumors are often located in close proximity to the facial nerve. Meningioma, schwannoma, epidermoid cyst, and many other tumors can involve the facial nerve. And in fact, facial nerve injury is one of the most significant complications during the surgery for these tumors. Therefore, precise knowledge of the nerve's anatomy helps in planning the surgical approach that minimize the risk of nerve injury. From another standpoint, the facial nerve can serve as an excellent surgical landmarks in skull-based surgery in the sense that accurate identification of the nerve can guide surgeons in navigating through the complex anatomical regions of the skull base. In summary, the facial nerve intricate anatomy and essential functions makes its preservation a top priority in skull-based surgery. That's my comment. Today's presentation will delve into the classification of lateral skull-based tumors, and I hope it will explore innovative strategies to manage and preserve the facial nerve during surgical intervention. To be quite honest with you, I'm really looking forward to watching this coming presentation provided by Professor Yuan Yansheng, not as a session chair, but as one of the learners. Professor, please start your presentation.
Thanks a lot for the kind introduction. Thanks a lot for the invitation of the President Yoko Kato and Professor Xu Bin. And it's my pleasure to stand here to share my clinical experience with the neurosurgeons all over the world. Really, it's my pleasure. So today, my topic is about the classification of lateral skull-based tumors and the management strategies for facial nerve. Maybe in my topic, I will give you another view from ENT doctor, how to see classification of lateral skull-based tumors and how to deal with the facial nerve, especially in your surgery when the facial nerve is damaged, and how we reconstruct it. So I come from ENT hospital, Fudan University, the lateral skull-based center. Generally speaking, for the anatomy and the subdivision of the lateral skull-base includes 6 areas. One is the nasopharyngeal region, and the eustachian tube area, and the neurovascular region, auditory field, and the hinge area and the infratemporal region. For the neurosurgeons, often use the surgical approach, like the retrosigmoid approach and the middle fossa approach. For ENT doctors, we often use translaminase or enlarged translaminase approach. So here is the anatomy of important organs in the lateral skull base. I think the most important thing is ICA, because in your surgery, if ICA is damaged, it will be a disaster, unbearable. And that is the facial nerve. So this is the ossicular chain. When we take out the ossicular chain, you can see clearly this the facial nerve, the ICA, and the jugular bulb, cochlea, and the semicircular canal. 3 semicircular canals, like this. Normally, we know on every segment of film, the facial nerve, it can occur the facial neuroma. And for the facial nerve in the cranial segment, often the facial nerve is go along with the S nerve, auditory nerve, right, like this. So this is the patient. The patient suffered the cholestoma in petrous bone, petrous apex. In the surgery, you can see clearly this is the ICA, and this is the cochlea, and this is the facial nerve. The surgery is under the microscope. So, with the microscope, we can clearly show the anatomy of these important organs: ICA, facial nerve, cochlea. In the cranial CP angle, like the cholestoma here, we remove the tumor. We can see clearly the lower cranial nerves, the facial nerves, and all the nerves here can see clearly. So, in my clinical experience, because we don't find any information on our textbook, there is no classification of lateral skull base tumors. This is just my experience. So classification of lateral skull base tumors, the first is temporal malignancy. Second, facial neuroma, cholestoma, paraganglioma, CP angle acupuncture neuroma, and others, meningioma or chordoma. For example, this is a acupuncture neuroma, often located in the CP angle, and this is a pathology. Normally here on T2, you can see the high signal. Okay. And the facial neuroma, the pathology is almost the same. So if the neuroma located in CPA, maybe it is difficult to do the differential diagnosis. But in other parts, I think it's easy to make diagnosis. Adenoid cystic carcinoma of the temporal bone. In the temporal bone, adenoid cystic carcinoma and the squamous carcinoma are the most important two types. And this is the pathology like this. Paraganglioma, it is very challenging for the surgery. It's very, very challenging. So the character of the image, so the paper and the salt, and the MRI image. For the pathology, you can see a lot of the small vessels here. And the parapharyngeal space tumor, like here, adenoma, this is, there are two important types in the pharyngeal space tumor. One is the adenoma, and the other come from the lower cranial nerves, the schwannoma. Endolymphatic sac tumor, it's very few. The disease often at the center of the endolymphatic sac and the posterior semicircular canal. It's a low-grade malignant tumor, originated from the epithelium of the endolymphatic sac. And the giant cell reproductive granuloma, the disease often located at the center of the mandibular temporal joint here. And you can see the giant cell in the pathology. Cholestoma of Patrick's apex. For the diagnosis and different diagnosis, I think you can use the MRI with DWI. You can see the high signal, so it's easy to make diagnosis, and the pathology is like this. So I show some clinical cases. I think in the lateral skull base surgery, there are still many challenges. So for the surgery, it's very difficult. Like this patient suffered with two sides cardiac body tumor with right side paraganglioma. So we often use the infratemporal approach to take out, to remove the tumor and the paraganglioma, like this. And for the reconstruction, after surgery of the lateral skull base, it's also difficult, sometimes very challenging. Like this patient, we use a supraclavicular island flap to reconstruct the ejection cavity. For the recurrent cholestoma and the brain abscess, so this patient has did 2 times surgery in the neurosurgery department. You can see the incision is done by the neurosurgeon in Shanghai Huashan Hospital, Professor Xu Bin's hospital. This patient do 2 times surgery, but the cholestoma recurrence and formed abscess in the brain. So they asked me to help. So I redesigned the approach. This approach, I think maybe something like the far lateral approach. So I redesigned the approach. First, from the neck, we control the ICA, and then we remove the cholestoma and the abscess. After we totally removed the cholestoma and the abscess, we use the sternocleidoid mastoid flap to reconstruct the operation cavity. So like this. So the image is before operation. You can see the tumor, the cholestoma and the abscess. This is a post-operation CT scan. So totally removed. So the Dr. Zhang sent me the recent message. This is a post-operation CT scan. Very good. All the carcinoma and abscess totally removed. And the second day, the doctor told me the patient is in good condition. The patient is very good. So, for the lateral scalp tumor, sometimes it's very difficult to do reconstruction. Like this patient, a big tumor, a malignant tumor, is very, very big. So it's a challenge to remove all the tumors and then reconstruct. So first we totally remove the carcinoma, and then we use the supraclavicular island flap to reconstruct the operation cavity. Okay, so let's move to the strategy for the facial nerve in the lateral scalp-based tumors. First is decompression. The second is transplantation. Transplantation in temporal bone or extracranial. So the breeding technique, we often do end-to-end or end-to-side. The breeding technique. The first is facial nerve displacement, like an anterior or posterior shift the facial nerve. So if the patient suffered Barrett's palsy or other reasons caused facial paralysis, we often do facial nerve decompression. So for the decompression, we do the decompression from the limbic segment to stylomastoid foramen. Here is the stylomastoid foramen, and here is the limbic segment. Open the superior limbic space and keep ossicular chain intact. The ossicular chain intact. So this surgery just do decompression of the facial nerve, and we don't damage the hearing. So after the surgery, the patient's hearing is normal. So after open the myelin sheath and flushing with the dexamethasone and finally covered with fascia, like this. And sometimes in the lateral scalp tumors surgery, we use the bone bridge technique of facial nerve. This is the malignancy of the temporal bone. The first step, we remove all the tumors. In the surgery, we use the facial nerve bone bridge technique. We leave the facial nerve untapped. With a very thin bone sheath. And finally, we use a platismal flap to reconstruct. The facial nerve transplantation in temporal bone, if the facial nerve neuroma is in the temporal bone, it's normally it's easy to reconstruct. So first we remove the facial neuroma, and we use neural nerve to do the transplantation, end-to-end anastomosis, like this. So for the transplantation, we often use the serial nerve or great auricular nerve. This patient suffered a very big facial nerve tumor. The tumor located in the temporal bone and in the parotid gland. So after we removed the tumor, we use the serial nerve with two branches to reconstruct. And for this patient is a deep lobe tumor of Pentagon. And before the surgery, the patient had already paresis. So first, we totally removed the tumor, and we do the anastomosis between the hypoglossal nerve and the facial nerve, end to end. This is in the early stage. Now we don't do this. We do end to side. Okay. Facial nerve and hypoglossal nerve anastomosis, and finally we use the sternocleidomastoid flap to reconstruct the ciliary cavity. For the paraganglioma, the surgery is sometimes very challenging. So, like this, patient suffered 360-degree encapsulation of ICL. We often use the anterior displacement of facial nerve. So, displacement of facial nerve and remove the acoustic the bone, the temporal bone, and control the ICL and the jungular one. Totally remove the tumor, and the patient, the function of the facial nerve is good. We often have some cooperation with the neurosurgeon. This patient is a dwarf and humpback. So the patient is in Huashan Hospital, Professor Xubin's department, and they asked me to do the surgery. So I used the translaminous approach to finally to totally remove the tumor. This is the post-operation CT scan. You can see the tumor totally removed. And the doctor sent me the message. So the tumor totally removed, and the patient very good. Sometimes for a very big, giant acute neuroma, it's very difficult to preserve the facial nerve function. Like this patient is about 7 centimeter, very big tumor. So normally even though you use the facial nerve function monitoring, and normally after you totally remove the tumor, and the function of the facial nerve is weak. So this patient, after we totally removed the tumor, and we found that the patient's facial nerve function weak, about 0.5 milliampere. So we just do something, try to help the function of facial nerve. We use a great auricular nerve graft just along with the facial nerve. So this is just post we did the surgery. And after the 3 months, so that this the patients almost can close his eyes. If we the CT scan show the tumor totally removed. If you see clearly, you can see the facial nerve and the graft here. The facial nerve and the great auricular nerve here. So sometimes for the lateral scalp tumors, like this patient, at the first sight, you find a tumor look at CP angle, or you might be thinking, oh, this is a cavity neuroma. But if you see clearly, you can see a mass to the middle fossa. So this patient is not a cavity neuroma. It's a facial neuroma. So first, we totally removed the tumor, and then we use the serial nerve to do transplantation. At the brain side, we use the glue to adhere here, and at the other side to the facial nerve, the vertical segment of the facial nerve. So we do the intracranial and external cranial transplantation, like this, from the brain side to vertical segment of the facial nerve. So after the surgery 3 months, you see the patient can't close her eyes. So this after 3 months. By the way, here I didn't do the mosaic because I already discussed with the patients. I explained that this is a study. It's just academic purpose. So all the patients, okay. So they agree. I take off the mosaic in order to clearly show the patient's appearance and the function and the facial nerve function. Okay. After 6 months, so you can see the patient already almost can close her eyes. So the appearance nearly normal, and the forehead you can see some wrinkle, a little, okay? Blowing like this. But after 1 year, the patient appearance is okay and can totally close her eyes like this. And after 1 year and 3 months, the patient looks almost nearly no. The appearance is beautiful. Okay, and the patient sent me her picture and the image. So it's okay. So the patient is satisfied with with her face and the surgery. This is another case. This patient suffered pyroganglyoma, and the first time the surgery was done by a neurosurgeon, and the neurosurgeon used the middle fossa approach. You know, the pyroganglyoma locates here. Middle fossa approach, that seems a little far from the disease. So using this approach, just removed a little pyroganglyoma. So very quickly, the pyroganglyoma recurrent and bleeding in her external ear canal, and the patient come to our hospital. So I did the surgery for the patient using infratemporal fossa approach. First, we control the ICA and take care of the nerves. Then we removed the tumor. Okay? Because this patient, when she came to our hospital, the patient has a totally hearing loss and totally paralysis. First step, we removed the tumor. But how to reconstruct her facial nerve function? This patient, I remember, this is the first time I do this technique. So I use a graft here. It's a great auricular nerve. Here is the facial nerve in the parotid gland. So this graft with the facial nerve, we do end-to-end anastomosis. And here is the hypoglossal nerve. We do the graft with the hypoglossive end-to-side anastomosis. Okay. This is a post-operation CT scan. We totally remove the tumor. So after surgery 1 year, the patient gave me a message. She got her driving license, and she take a picture. So I take this picture here. You see her face appearance sounds okay. At this time, the patient is not married. She didn't have a boyfriend. But after I did surgery for her 1 year, she find so the patient told his story. Now she is married and pregnant. She is very happy. She said, thanks a lot for me. And first time she did surgery in the neurosurgery department, she got totally paralysis and hearing loss. And the second time, I did surgery for her. After 6, look at her mouth moving. it's okay. She told her story, the 2 times operations, and now her face sounds okay. She is happy and satisfied. And it's so currently follow up. She gave me some message. She told me her friends, many friends told her her face is more and more beautiful because the eye, the mouth. She is very happy and satisfied with this surgery. But how to recover the facial nerve function like this? Sometimes the facial neuroma are very big, as a middle fossa like this. After we removed the tumor, but we can't find the upside of the facial nerve. We can find the lower side of facial nerve in the parotid gland. But when you totally remove the tumor, the facial nerve retract in the brain, we can't find it. So how to reconstruct like this patient? So this patient is a police woman, and she go to a lot of hospitals. All the ENT doctors and neurosurgeons told her, even though we can remove the tumor, but we can't reconstruct the facial nerve function. That means the patient will get totally paralysis in the future. And finally, the patient come to our hospital, and I did the surgery for her. Here, I want to say, if the patient suffered a very big facial neuroma at the middle fossa or at the CP angle and the middle fossa like this, so after we do the surgery, how to reconstruct? Here we introduce a surgery, the approach, the technique. So first, we totally removed the tumor, and then we use a graft, like the serial nerve or great auricular nerve, to the facial nerve in the parotid gland. We use end-to-end anastomosis, and to the hypoglossal, we use end-to-side anastomosis, like the bypass. So we use this technique to reconstruct the facial nerve function. And we already published the paper in 2019. So this patient, I said just now, she's a policewoman. So after the surgery, half year, the patient can't close her eyes. And 1 year, the patient, the wrinkle and, closing eyes, sounds okay. So 1.5 year, so the patient said, so she said hello to everybody, and she introduced her story. She suffered a big facial nerve neuroma in the middle fossa, and she went to a lot of hospitals. All the doctors said it's very difficult and challenging to remove the tumor, and it's more difficult to reconstruct the facial nerve function. And if you do the surgery, maybe in the future you will get totally paralysis. So finally, she came to our hospital, and I did a surgery for her. After 1.5 years, she nearly recovered. I can't say it's very, very perfect, but she can go outside, and she can go to work, and she is satisfied with this surgery, and she wants to say thanks to me. And now she lives a happy life like this. Oh, sorry. So this is the paper we published in the World Neurosurgery. If you have some interest, you can find it. The summary: two challenges in the lateral skull-based surgeries, the ICA and the facial nerve function preservation, and the functional reconstruction. And the second, when intracranial segment of facial nerve damaged, it can be reconstructed by end-to-end anastomosis of facial nerve and hypoglossal nerve. Third, intracranial and external nerve transplantation can be used in the one-stage operation when the facial nerve is damaged in CP angle region surgeries. By the way, in 2023, last year, I led the development of China's first expert consensus on facial neuroma. Because this is in Chinese, so maybe in the future we can explain more later or in the future. Okay. At last, I want to introduce our team. I worked in EENT Hospital, Fudan University. This is our center, lateral skull-based tumor center. In our team, we have ENT doctors, and we also have neurosurgeons, intervenists, pathologist, and a radiologist. So this is MDT. This is our center. Thanks all for your attention. It's really my pleasure to share my clinical experience with all the neurosurgeons. Thank you.
Thank you very much, Professor Yuan. Yeah. Thank you very much, Professor Yuan. It looks just a magic. First you went over the detailed anatomy of the facial nerve, and then you briefly introduced various types of tumors, including a big chunk of it's amazing, like malignant temporal bone tumors and epidermoid, like big paraganglioma and lymphatic tumors. And then after that, you provided a detailed strategy to avoid injury of the facial nerve and to reconstruct or preserve the facial nerve function. And then lastly, you showed me how to reconstruct the facial nerve in the same day as the tumor removal using the combination of end-to-side and end-to-end anastomosis of the facial nerve. So everything is just great, and particularly, I was only good cosmetic outcome, but also husband and baby for the, pretty girl, which is totally amazing. How much recovery can we anticipate when you do facial nerve reconstruction? I don't think it's 100%, right?
No, 100%. Normally, whatever for in all the way to reconstruct the facial nerve, if you do transplantation, the best effect is Hafs-Branch bank level 3. This is the best effect. You can't nearly normal. You can't get perfect, totally recover. You can't get this post effect, surgery effect, 100% recover. No, I think nearly 70 to 80% recovery. But for all the patients,
thank you very much.
For the patient we did the surgery, she or he can go outside, and she can go to work. If you don't look at her face clearly, it seems nearly normal. Actually, they just after 75% like this total recover.
Okay. All right, thanks. And can you make another comment on the timing of reconstruction? I think you did reconstruction just on the same day tumor removal.
It depends on if a neurosurgeon like you are doing a surgery for a carcinoma. During the surgery, if the facial nerve damaged, so totally damaged, so I can help to do the transplantation from the brain stem side to the peripheral facial nerve to do the transplantation at the same time. Second, if you find after your surgery or half a year, the patient's face totally paralysis or nearly paralysis. No, not very good. At least no more than 1 year. Normally, if less than 1 year, we can do second stage reconstruction by using and to side facial nerve to hypoglossive and stomosis bypass to reconstruct for the patient.
All right, thank you very much. Any comments from our ACNS side?
So far we have none. I think you can give your concluding remarks.
Every time I watch this ACNS webinars, I actually learned quite a bit. So this time, from not only from the neurosurgeon side, but also from the ENT side, I learned a bunch of new knowledge, new anatomicals, and new surgical skills. And I'm totally impressed by this webinar. So thank you very much for all the participants and all the ACNS chairs, and then Dr. Roger and Dr. Yoko Kato and other ACNS members. Thank you very much for this great event. Thank you.
So thank you very much. I'd like to close this officially now. We indeed had a wonderful session with Professor Yuan Yasheng. So on behalf of the Education Committee of the ACNS and the President Professor Yoko Kato, I would like to thank both the speakers of today, Professor Salim Senturk and Professor Yuan Yasheng, as well as the chairs, Professor Hyun Sing Kim and Professor Hirotaka Hasigawa, for the time and support for the ACNS webinars. A very special thanks to Professor Shubin for broadcasting this webinar on the WeChat channel. As I mentioned earlier, there are around 540 people who have logged in through all different channels all around the world. Thank you to my dear co-host Liu Bun Seng for joining me today. So until we all meet online tomorrow, it is bye bye from all of us. Thank you very much for joining.